Hello everyone, welcome to YouTube Live on our channel. Good evening everyone. Here we go with our today's live session, Physiology SBA Masterclass. And if you have joined, do let me know in the live chat. I'm waiting for your answers. Right? So everybody, okay? So what we are going to do today is that we are going to talk about 20 SBA questions, right? We are going to do 20 single best answers for the physiology. So we are going to talk about the questions which are important for exam point of view. And simultaneously, I'll be giving you the explanations for those questions. And we'll be talking about some extra bonus points also. Mind you, you can take it that out of these 20 questions, you can expect at least 2 to 3 questions in your exam. So you know that these are so important for you. So this 20 minutes, if you spend 30 minutes with me now in this session, definitely you are going to get 2 to 3 questions right in your exam. So now you know that how important it's in. Yes. Very much welcome. Very much welcome. Yes, yes, yes. Thank you. Thank you for your responses in the live chat. And please do keep on responding. Right. So here we go with let's start the session. So let's start the first SBA. Okay. So first SBA is a 52-year-old patient attends the clinic for the results of her bone density scan, right? So as we go about this question, so 52-year-old patient attends for the results of her bone density scan. Her T-score is minus 2.2. She tells you she has previously fractured her fifth metatarsal and patella. Following a fall from a bike, you diagnose her. So what is your diagnosis? This question, this is very important. This is a part of data interpretation as well. You can have this question in your paper 1 for the physiology, or you can have the similar question, this question in the paper 2, which will be a data interpretation question, right? Because we are interpreting the report of the T-score. So now what does this score goes with? Yes, yes, you can answer in the live chat. Yes, thank you, very good. So basically, if we go with the classification, then according to the classification, this patient is osteopenic. Yes, it is osteopenia. So how do we classify? Let's talk about this, right? So how do we classify? So we classify this as a normal. The T-score, which is normal, is -1 and higher. So, you know, now here the values are in minus, right? So bigger the value, it is actually the lower value, right? So 1, 2, 2.53, as we are going higher in the numbers, because of the minus sign, actually the values are decreasing. So the normal T-score is -1 and higher, while the osteopenia is -1 to -2.5, and osteoporosis is -2.5 and lower. What about severe osteoporosis? It is -2.5 and lower with one or more of the fragility fractures. So this is how we are going to classify this. Now you can have any value in your exam, and if you just follow this chart, you can easily answer your question. So this is the first question which we are going to talk right now. Now, this is important. As I told you, this could be a physiology question. This could be a data interpretation question. So either way, you can answer this question very well. Now, moving on to the next, as we are talking about the bones. So here is an important point from the bone physiology. So what is that? 99% of the body calcium is stored in the skeleton as the calcium phosphate salts. 99% of the body calcium is stored in the skeleton as the calcium phosphate salts. There are several calcium phosphate salts, and the most abundant in the bone is. Yes, I'm waiting for your answers. So the most abundant in bone is, you can answer, keep on answering in the chat. Right, so the most abundant in the bone, yes, you are right. It is hydroxyapatite. So this is a very important exam question. Let me tell you, calcium metabolism. Calcium metabolism is a very, very important part for your part 1 exam. Whether we talk about the physiology or we talk about the pathology or data interpretation, calcium is a very, very important. Calcium metabolism, what is the level, how much is the ionized form, which is the most commonest form, most abundant one. So all these questions are very, very important part. And they do sometimes give you the values about the enzymes, like what is the calcium level, what is the serum alkaline phosphatase, what are the various hormones which affect the calcium metabolism. All these are very, very important and very favorite questions of RCOG. So this is extra tip and the bonus point before we move on to the next question. So as I told you, the calcium is very important. So this is another question about the calcium. So what is the normal range for adjusted serum calcium? Yes. Anybody? Yes. Keep answering in the chat down, right? I could see. So what is the normal range for adjusted serum calcium? Yes, you are absolutely right. It is going to be, yes, perfect. So it is basically your 2 to 2.8 millimoles per liter. That's absolutely correct. Moving on to the next question. What is the typical weight of term uterus? What is the typical weight of term uterus? So as we know, there are changes in the uterus in the time of pregnancy. It increases in size. There is hyperplasia. There is hypertrophy. So what happens to the weight, right? And what is the non-pregnancy weight and what happens to the weight at term? So the non-pregnancy weight is only 40 to 50 grams, right? It is only 40 to 50 grams. That is the typical weight of the term uterus. Now, of the non-pregnant uterus, sorry, it was a mistake. So it's a non-pregnant uterus. It was 40 to 50 grams. So what happens in the pregnancy? This could reach up to 1100 to 1200 grams, right? So non-pregnant uterus weight is 40 to 50 grams. Volume is approximately 10 ml. And in the term uterus, the weight is 1100 to 1200 grams. And the volume is approximately 5000 ml. Perfect. So this is how we are going to remember this. Now, moving on to the next question. So, minute ventilation in pregnancy increases due to which of the following? We do have a changes in respiratory system as well. So we do have a changes in respiratory system. So minute ventilation in pregnancy increases due to which of the following? What acts on the respiratory system, right? To increase the minute ventilation. So what are the factors responsible here? Is it the effects of gravity uterus on the diaphragm, the pressure which is coming? Or it is because of the hemodilution leading to dilutional anemia, increased renal excretion of bicarbonate, increased circulating estrogen, or increased circulating progesterone? What could be the possible thing? Yes, perfect. It's increased circulating progesterone, which leads to this change in the respiration. So what happens is that the effect is believed to be due to elevated circulating progesterone levels. Progesterone directly stimulates the ventilation by increasing the sensitivity of the CNS receptor centers to CO2. This leads to an increase in the minute ventilation, which reduces the CO2 levels. So what happens when we hyperventilate? When we hyperventilate, we wash off CO2. And this CO2 is basically causing the acidosis. So this is basically responsible for the acidic ions because it forms the carbonic acid, right? So if we wash off acids, that is, we wash off CO2, the carbonic acid decreases. And as the carbonic acid decreases, the alkalinity is increasing. Now, to maintain the pH, what has to be done? The kidneys will compensate by increasing the excretion of the bicarbonate, right? Because the acidity is decreasing, they are washing off CO2. So carbonic acid in the blood is decreasing. So as the carbonic acid is decreasing, the acids are decreasing. So what happens to the base? Base has to go down to maintain the pH. So base will go down by as the bicarbonate is excreted. So that's how it's going to. So if we look at the options, the increased renal excretion of bicarbonate is also correct. It is also happening in the pregnancy, but that is not causing the minute ventilation increase, right? Minute ventilation increase is causing the CO2 wash off. Therefore, the renal excretion of bicarbonates is increasing. So don't confuse this, okay? Increased renal excretion of bicarbonate is the end product, which is happening because of the minute ventilation increase. But why is the minute ventilation increases? The cause is increasing circulating progesterone, right? So E is the correct answer here. Now, I move on to the next question. So cardiac output is calculated by which of the following formula? So cardiac output is calculated by which of the following formula? So it is basically, is it the end diastolic volume and systolic volume, or it is the basically the end diastolic volume minus end systolic volume, or is the multiple? So what it is actually? It is stroke volume multiplied by the heart rate. So it is stroke volume multiplied by the heart rate, right? So cardiac output is calculated by the formula of stroke volume multiplied by heart rate. Coming to the next question, that is the fifth question. So oxytocin causes increased myometrial contractions via which of the following messenger pathways? Oxytocin causes increased myometrial contractions via which of the following messenger pathways? So what happens? What causes the increased myometrial contractions? Yes, I'm waiting for your answers in the live chat. Let me see. Yes, thank you for answering. Very good. So basically, yes. So there is some confusion, like some are answering right, some are answering wrong. So what it is basically the A option is the correct answer, right? So A is the correct answer. It is the inositol phosphate pathway, which leads to increased myometrial contractions. So what happens? The calcium needs to enter the cell to stimulate the muscle contraction. So how can the calcium enter into? So it activates the phospholipase C and it produces the IP3, inositol triphosphate, which triggers the intracellular calcium ion release. So oxytocin activates phospholipase C to produce inositol 1,4,5-triphosphate, which releases the calcium from the intracellular stores. These are thought to be other mechanisms by which myometrium is stimulated by the oxytocin, including the increased sensitization of the myometrium and increased calcium entry into the cells. CAMP and the protein kinase A, they are the inhibitory pathways. So they inhibit the myometric contractility, right? So A is the correct answer. Now, regarding the closure of the ductus arteriosus after birth, which of the following most accurately describes the mechanism leading to closure of the ductus arteriosus? So, now ductus arteriosus is a very, very, very important shunt which is there between the pulmonary artery and the aorta, right? So this is the very important pathway in the fetus. So what happens when the baby is born? So in that case, which is the correct answer, what leads to the closure is the basically what happens in the PO2, what happens in the bradykinin or the prostaglandins. So yes, C is the correct answer. Increased arterial PO2, increased bradykinin and decreased prostaglandins E2. Increased arterial PO2, increased bradykinin and decreased prostaglandin E2. C is the correct answer. So as the baby is born, the lungs become active and the baby starts taking directly the inhaling, and inhaling he will take the oxygen in, right? So increased arterial PO2 will be there and increased bradykinin is there and decreased prostaglandin E2 is there. So increased arterial PO2, increased bradykinin and decreased prostaglandin E2 is there, right? So C is the correct answer. Normal closure of the ductus arteriosus is brought by several mechanisms. Upon delivery, the newborn baby's first breath inflates the lung, and this causes a rise in PO2. Oxygen is known to cause the construction of the ductus arteriosus in vivo and in vitro. In addition, the decreased vascular resistance means the pressure within the lumen of the ductus arteriosus drops, aiding closure. In addition, when the lungs are inflated, they produce the bradykinin, which stimulates the smooth muscle constriction of the ductus. The most important factor is thought to be the drop in prostaglandin E2. Prostaglandin E2 maintains the patency of the ductus in the unborn child, but after the birth is metabolized in the lungs and its level falls rapidly within 3 hours of the birth. So therefore, if we need to keep this duct open for some of the cardiac surgeries, sometimes in cases where the baby is born with a congenital heart disease and you need to operate on the baby, in those cases, sometimes we need to keep this duct patent so that baby can still maintain the oxygen. So in that case, we give the prostaglandins to maintain the patency of the duct. Which of the following is the potent stimulator of aldosterone? Aldosterone, an important hormone which is responsible for the sodium and potassium and water metabolism, right? The levels of the sodium, potassium, and the water, it's very, very important. Now, what is the most potent stimulation for the aldosterone? We always read it in the form of water and the sodium retention. So is it really working only on the water or sodium retention? Or there is something else which is the potent stimulator? So what do you all say? Yes. It's not the sodium, it's the potassium, which is the potent stimulator of the aldosterone, right? So if you haven't read it, it's difficult to answer because we never talk about the potassium levels maintenance. We talk about the sodium and water. So when we talk about the sodium and water, that only comes to our mind. But it's the hyperkalemia, which is the most important stimulus for the aldosterone. So hyperkalemia is arguably the potent stimulator, most potent stimulator of the aldosterone. Juxtaglomerular cells will also secrete renin that will ultimately stimulate the aldosterone production in response to hyponatremia and hypotension. So JG cells will also secrete the renin that will ultimately stimulate the aldosterone production in response to hyponatremia and hypotension. Following parturition, uterine contractions called after pains may typically continue for how long? So this is the next question. So following parturition, uterine contractions called after pains may typically continue for how long? Yes, I'm waiting for your answers in the live chat. Please keep answering. Yes, I can see your answers. And it's good. It's good. Good, good. Yes. So what's going on here? So basically, yes. So the correct answer here is, I'm afraid there is no correct answer here. This is none of the above. Yes, this can happen in exam also. We sometimes can have the option of none of the above as well. After pains may continue for 2 to 3 days. So this is none of the above. We don't have this option. If you see, it's 2 to 3 hours. It's 12 to 24 hours, which is equal to 1 day. 7 to 14 days, and then 21 to 28 days, which is not the correct answer. 2 to 3 days is the best answer. Breastfeeding may intensify the pain due to stimulation of oxytocin, which causes the uterine contractions. Coming to the next question, that is SBA 9. At what gestational age does the luteoplacental shift occur? We know that initially the corpus luteum is going to help with the production of the hormones and nurturing the fetus. But later on the placenta takes over, right? So later on the placenta takes over. So what is the time when this shift occurs from corpus luteum to the placenta? That's a very, very important question. And let me tell you, this question has appeared in the recalls in the past papers multiple times, right? So at what age the luteoplacental shift occurs? So the correct answer is yes. It's 6 to 8 weeks. At 6 to 8 weeks, the luteoplacental shift refers to the point in time where the placenta takes over from the corpus luteum as the chief site of production of estrogen and progesterone in sufficient amounts to maintain the pregnancy. This typically occurs around 6 to 8 weeks of gestation. This graph, this is a very, very important graph for the exam. You can have a picture, a graph posted there, and then you have to answer what it is, right? So what this graph is showing. So that's a very, very important point here. Okay, so if we look at this graph, then this graph, you see that initially it is low, then it goes high, and it becomes the human chorionic gonadotrophin, right? So HCG is there, and this is estrogen, and this is progesterone, right? So estrogen and progesterone, they keep on rising up to the top, while the HCG, it rises and then it falls, and then it remains plateau. See, it does not come to the end of pregnancy. So it still remains high, but it then plateaus, right? So this is the graph of HCG, estrogen and progesterone in the pregnancy. HCG is most important out of these as per the exam. Hormones are all important. I'm not saying the hormones are not important, but as per from the exam point of view, this HCG graph is the one which appears again and again in the exams. Now coming to the next question, that is the SB 10. In the third trimester, anemia is defined by, again, a question which can be part of the physiology, which can be part of pathology, and which could be a part of data interpretation. So in the third trimester, anemia is defined by, yes, how do we define? What is the level here should for the third trimester? Yes. So keep answering in the live chat. Yes, I'm looking at the answers. Good, good, good. Very good. So it's basically, yes, everybody is correct here. Perfectly correct here. So it is your hemoglobin level less than 10.5 grams per liter or 105 grams per liter, or you can say 10.5 grams per deciliter, right? So that's the correct answer. Anemia in pregnancy is defined by the British Committee for the Standards in the Hematology guidance. First trimester, it is basically the hemoglobin level less than 110. Second and third trimester, it is less than 105. And postpartum hemoglobin, this is less than 100. Perfect, right? So first trimester, hemoglobin less than 110 grams per liter. See, here the values are grams per liter. If you take them as grams per deciliter, then it becomes 11, 10.5, and 10, right? So that's how it is. So that finishes our 10 questions. But we have 10 more to go. So we'll keep practicing with more questions. Okay, so here we go. SBA 11. Which of the following is the primary site of prostaglandin E2 production, right? Which of the following is the primary site of prostaglandin E2 production? So, which is the most primary site? There are two prominent sites. Yes, perfect. The answer is correct. So, corpus luteum and placenta, they are the two most prominent ones, but placenta is the most important primary site. Prostaglandin, sorry, it's not a corpus luteum. Corpus luteum produces that, but not to that extent, right? So placenta is the most important one, placenta and ductus arteriosus. So prostaglandins are produced in almost all nucleated cells. The placenta and the ductus arteriosus in particular have high quantities of the COX enzyme isoforms required for the synthesis of the PGE2. Although all the cells produce, but as I said, placenta has the highest one. So that's the correct answer here. Right. Good. Very, very good. I can see all the right answers in the live chat, and thank you for joining in today and answering the questions right perfectly. So here we go with our next question. That is the SBA 12. Which pregnancy hormone? During pregnancy, which hormone inhibits the lactogenesis, right? So, during pregnancy, which hormone inhibits the lactogenesis? Lactogenesis, milk production. So, which hormone actually keeps inhibited the lactogenesis in pregnancy? Because we know that the prolactin is continuously rising, right? Prolactin is continuously rising in pregnancy, but still the woman is not producing the milk, right? On the other hand, if we have a slight rise in the prolactin, we have galacturia. So there is something happening in the pregnancy which is not allowing the milk production in spite of higher levels of prolactin. So what's that? Yes. Keep answering in the live chat. Thank you. Yes. C is the correct answer, estrogen and progesterone. These hormones are raised to such an extent that they basically does not allow the milk production. So prolactin levels, they rise steadily during the pregnancy, during which time it promotes the mammary growth. The estrogen and the progesterone inhibit the lactogenesis, and it is only with the loss of these placental steroid hormones at term that prolactin exhibits its lactogenic effect. Estrogen and progesterone, they inhibit the lactogenesis, that is the milk production, and it is only with the loss of these placental steroid hormones. So as the pregnancy ends, this estrogen and progesterone, they come down, right? They come down, and once they come down, they decrease the prolactin comes into the action. Now the prolactin can act because the estrogen and progesterone has come down. So the power of prolactin, now he can just go and push it and the leptogenesis starts. Okay, so going to the next one. So SBA 13. Regarding cardiac examination during pregnancy, which of the following findings should be considered pathological? Regarding cardiac examination during pregnancy, which of the following findings should be considered pathological? Now we know that there are certain changes in the pregnancy, right? So we can find certain signs also which are absolutely normal. But what is the finding among those which is absolutely considered to be pathological? Keep answering, keep answering. Thank you, thank you. Yes, this is diastolic murmur. Diastolic murmur is the correct answer, right? So diastolic murmurs should be considered pathological until proven otherwise. See, systolic murmur can be there, right? Why? Because the cardiac output is increased, right? So more amount of the blood flows into the circulation, and that large amount of the blood which flows in the circulation, that leads to the systolic murmur, right? But the diastolic murmurs, that is the filling time. So diastolic murmurs should be considered pathological until proven otherwise. Now, the following are common and typically benign findings in the pregnancy. So these are the findings which you can find in the pregnancy, but they are physiological. They are kind of because of the physiological changes in the system. So third heart sound after mid-pregnancy, that's normal. Systolic flow murmurs are common. Left axis deviation on ECG is common. And the sagging ST segments and inversion or the flattening of the T wave in lead 3 may also occur, right? So, third heart sound after mid-pregnancy, systolic flow murmurs are common. Left axis deviation on ECG is common. And sagging ST segments and inversion or flattening of the T wave in lead 3 may also occur. Okay. All well till now? Any queries? Everybody okay? You can leave your queries also in the chat box. I'll be happy to answer your queries as well. During pregnancy, the GFR changes as follows. What happens to the pregnancy GFR, right? So how does it go? So GFR increases by 40%, right? So GFR increases by 40% during pregnancy. Yes, that's the correct answer here. So GFR increases by about 40% during pregnancy, and that is typically apparent by the end of first trimester. GFR increases by about 40% during pregnancy, and that is typically apparent by the end of first trimester. So that's the correct answer. So renal changes in pregnancy. That's a very, very, very important. Renal physiology, what increases, what decreases. They are very, very important points for the exam questions. Coming to the next question. SBA 15. Where in the kidney is the majority of the bicarbonate reabsorbed, right? Why we are saying reabsorbed? Because once it is filtered from the glomerulus, and after that, that is absorbed back into the circulation. So where in the kidney is the majority of bicarbonates reabsorbed, right? So that's basically the proximal convoluted tubule. Yes, you are correct. It's proximal convoluted tubule. Thank you so much for answering right in the live chat. And thank you for joining today. So this is proximal convoluted tubule. Now let me tell you one very important trick here. If they give you anything and you don't know where it is reabsorbed, particularly if we are talking about the bicarbonate, phosphate, potassium, sodium, urea, right? So it is basically, if you are talking about all these, then you can put PCT as an answer very confidently, because almost majority of the things, 99% of the things are absorbed in the PCT, proximal convoluted tubule. So the proximal convoluted tubules reabsorbs the following: glucose 100%, amino acids 100%, carboxylate 100%, bicarbonates 85%, phosphates 85%, potassium 65%, sodium 65%, urea 50%. Calcium, magnesium, and the water, they are variable reabsorption throughout nephrons. Okay, coming to the next question. Which of the following hormones inhibits the galactopoiesis and the lactogenesis postpartum? So, which of the following hormones it inhibits the galactopoiesis and the lactogenesis? Now we know that in pregnancy we said the lactogenesis is inhibited by the estrogen and progesterone. So it's very important that you read the question carefully, whether it's being asked in the pregnancy or in the postpartum period. So in pregnancy, it's the estrogen and progesterone. But in the postpartum period, estrogen and progesterone is not working. So now what can inhibit the lactogenesis? So now comes the inhibitor. So inhibitor is the dopamine. So dopamine is the correct answer here. Galactogenesis and the galactopoiesis and the lactogenesis, they are stimulated by the prolactin. Dopamine released under hypothalamic control inhibits the prolactin production. Estrogen and progesterone, they inhibit the lactogenesis up until term. So remember what they are asking. If they are asking in the pregnancy, then estrogen and progesterone are the main inhibitors. But if they are asking in the postpartum period, then the prolactin is the main inhibitor. Prolactin is the stimulant and dopamine is the main inhibitor. Okay, so here we move on to the next question, that is SBA 70. You review a patient who is 34 weeks pregnant. She complains of gradually worsening itching over the past 6 weeks, particularly to the hands and feet, which is worse at night. You order some bloods. Which of the following would you normally expect to increase in the third trimester? Now, the question is about, they have given you the scenario, right? They have given you the scenario of obstetric cholestasis. They are giving you that 34 weeks pregnant patient is there, and there is itching over the hands and feet, which is worse at night, a typical scenario of obstetric cholestasis. So you may immediately think about the bile acids, because bile acids are the one which are increased in obstetric cholestasis. But no, that's the trick here. Which of the following would you normally expect to increase in the third trimester? So if you read the question in the end, it is not about the obstetric cholestasis or nothing related to the scenario above. They are just asking normally, in a normal physiology, what increases in third trimester? So the message here is very clear that we should read the question very carefully. There could be a long scenario on the top, but be careful to read the last sentence of the question, because it is going to make the difference in your answer, right? So here, and many times the similar thing is there in the exams as well. You have a very different last statement, which has nothing to do with that big scenario on the top, right? So be very careful and read your last question very well. Which of the following would you normally expect to increase in the third trimester? Yes, it's ALP. ALP, alkaline phosphatase, that is the one which raises normally in pregnancy. So ALP can increase up to 3 times the normal non-pregnant value in third trimester. All of the other tests above typically decrease during pregnancy. Fine. So here we talk about the SBA 18. So here another question about the lactogenesis. So you see how important it is. One of the questions of this lactogenesis can come in your exam. So we have till now talked about we talked about what inhibits the lactogenesis in the pregnancy. So we said that is estrogen and progesterone. Then we asked about what inhibits the lactogenesis in the postpartum period. So that's the dopamine. Now the question is very much direct. Lectogenesis as term is stimulated by which hormone? So which hormone stimulates that? Yes. Keep answering in the live chat. Yes. Thank you. Thank you. I could see your answers perfectly correct. Now everybody know that. You will remember in the exam and that will make your one question right. You can then remember me in your exams, right? Because just remember that we discussed it here and so you did it right. So basically it is prolactin. Yes, absolutely correct. It's the prolactin, right? So prolactin is a hormone which stimulates the lectogenesis and the ejection, the milk ejection reflex that is stimulated by the oxytocin, right? So that is by the oxytocin. So don't confuse both of these things. There are two things, milk formation and milk ejection, right? So milk formation is because of the prolactin. Milk formation is because of the prolactin, but the release, the ejection, that is because of the oxytocin. So please remember that very nicely. The answer here is D, not A. Oxytocin stimulates the milk ejection reflex in response to suckling. Galactopoiesis is maintained by the action of prolactin, which we just discussed in the previous slide. Alveolar gland proliferation and differentiation occurs under the actions of the estrogens, progesterone, HPL, and prolactin. Prolactin stimulates the lectogenesis when not inhibited. So these are the few statements which are important for this question. Now, coming to SBA 19. Regarding the use of erythropoietin, which is recombinant human erythropoietin, in pregnancy, which of the following statements is correct? Right? So, which is the correct statement for the use of erythropoietin? So, it has shown to have adverse maternal effects when used antenatally. It has been shown to have adverse fetal effects if used antenatally. It has been shown to have neonatal effects. And the use of is only recommended for the non-end stage renal anemia or none of the above. So basically, the correct answer is none of the above. None of the above is the correct answer here. What does the guideline say? Guideline says that recombinant human erythropoietin is mostly used in the anemia of the end-stage renal disease. So instead of the last thing which says that it is recommended in the non-end-stage renal anemia, it's actually opposite. It is recommended in the anemia of end-stage renal disease. So it has been used both antenatally and postpartum in the women without end-stage renal disease, without any adverse effects in maternal, fetal, or the neonatal effects. So it does not have any adverse effect on either the mother or the fetus or the neonate. So the role of the erythropoietin in the non-end stage renal anemia is still to be established and should only be used in context of the controlled clinical trials. So right now, the clear-cut indication is that erythropoietin should be used in the anemia of end-stage renal disease. Coming to SBA 20, and of course, this is the last SBA for today. Which of the following is the primary stimulator of uterine involution following the childbirth? Which hormone stimulates the uterine involution? Uterine involution is a very important part in the postpartum period. So which is the one which is responsible? Something which will contract, yes, of course. So it is going to be oxytocin. So oxytocin is the one which leads to myometrial contraction and it leads to it helps in contracting the uterus and hence the involution, which is very, very important point. Now, I promise you will have at least 2 or 3 questions in the recalls in your paper from this particular question. So remember this, okay? And when you do this, do remember MRCOG courses by Dr. Bhavna Khera. Here are our contact details. If you ever want help from our side, we do have courses for part 1, part 2, and part 3. For part 1, we just say that in 60 hours, you can prepare for your MRCOG part 1 with us. If you have booked your exam, you are not sure where to go about, then this is the number to be called upon. I have met many students who keep thinking about that. I want to do part one, I want to do part two, but they just keep on thinking because of the terror, the scare. Mind you, you just come, see our website, take a trial, and I'm definitely sure all your scare is going to vanish away. So do it now, sometimes later never comes. So if you are just postponing it next year, maybe it never comes. So do it now. You are at a right place. Thank you so much for joining today, and see you all in the next YouTube live session. Meanwhile, thank you for answering in the live chat, and I would be happy if you can leave certain topics in the live chat which you want to discuss, and we will certainly take up those for the discussion. Thank you so much for joining today.